Keratoconus Beyond Conventional Management. My name is Vishal Janji, and my co-moderators are Dr. Shizuka Ko and Dr. Namta Sharma. The panelists are Dr. Gokhale and Dr. Padmanabhan. Dr. Shetty is running late, so we'll start with Dr. Shizuka Ko from University of Osaka. She's going to present on colony biomechanics.
Actually, this is too high. Okay. Hi. Okay. Can I start my presentation? Better to hear? Okay. Thank you. Good morning, everybody. It is my great pleasure to give a talk here. I'd like to thank a committee member of AIOC. Keratoconus is a progressive corneal ectasia with onset typically in the second decade of life. It presents bilaterally, although often asymmetrically. It is characterized by stiffening, distortion, and apical thinning of the cornea, leading to visual deterioration due to irregular corneal astigmatism. Among the corneal disorders, it is not a rare disease, but as mentioned frequently, it is frequent rare disease. Thank you. Okay. So I'd like to start with a very famous phrase by Professor Cynthia Roberts. She actually wrote this phrase in the editorial in the Journal of Refractive Surgery more than 20 years ago. The cornea exhibits both viscous and elastic biomechanical behavior. Excuse me? Okay. So what is the biomechanics? So biomechanics is the study of the mechanics and application of the structure and motion of human organisms. When we think about the biomechanics of cornea, biomechanics of cornea can affect its functional responses and greatly impact vision. The pathophysiology of keratoconus includes genetic disorder, biochemical disorder, biomechanical disorder, and environmental disorders as well. It is recently reported that the corneal biomechanical changes may occur before the curvature changes in the development of keratoconus and ectasia. So it is very important to measure the corneal biomechanical properties. Currently, there are two commercially available devices for measurement of corneal biomechanics, ocular response analyzer, and Corvis ST. Actually, in our university hospital, we are using only Corvis ST, so my presentation is based on the data from Corvis ST. So Corvis ST is a non-contact tonometer that allows investigation of the dynamic reaction of the cornea to an air impulse. Shown here is movies from the normal eye and keratoconic eye. You can see the remarkable differences in the two movies. Actually, Corvis ST actually provides so many parameters, so I'd like to focus on the very important ones. So this is a display from Vinguera's clinical report. So we can just look at the bottom right of the this display. So this blue box. So right end of the blue box, you can see the color bar. This is Corvis Biomechanical Index, CBI. This is based on the corneal thickness profile and deformation parameters. Again, Corvis Biomechanical Index, CBI, is calculated on the corneal thickness profile and deformation parameters. It is reported that it is useful to detect clinical keratoconus and subclinical keratoconus as well. It ranges between 0 and 1. Recently, tomographic biomechanical assessment is also introduced. The point is actually it combines the biomechanical assessment and tomographic assessment. So actually both devices are Oculus. So Corvis ST for biomechanical assessment and Pentacam for the tomographic assessment. The combined index is called as Tomographic Biomechanical Index, TBI. It is called that it can enhance the ectasia detection. Actually, this is a display from the Corvis ST. You can see the CBI and BAL-D and TBI. First keratoconus, this is a fellow eye of very asymmetric ectasia. This is defined as the fellow eyes of very asymmetric keratoconus, which does not present with clinical or topographic signs, while one eye manifests with clinical keratoconus. According to the global consensus on end-ectatic disease, keratoconus is often asymmetrical between two eyes, but it says true unilateral keratoconus does not exist. However, unilateral ectasia may occur. So we cannot say unilateral keratoconus, but we may say unilateral ectasia. This is a first study result of the first study, which says TBI can detect more efficiently compared with BAL-D or CBI. Actually, if you see the pink box in the TBI area, you can see the separate TBI can separate the fellow eye of VAE. Let me show you the clinical cases from our hospital. This is a case of very asymmetric ectasia. Definitely, the left eye is clinical keratoconus, but the right eye has a normal topography based on the placebo topography. And also, his right eye has a good visual acuity. When we look at the biomechanical or tomographic biomechanical assessment, you can see that BAL-D from Pentacam and CBI from Corvis are okay, but the TBI, tomographic biomechanical assessment, says this is an abnormal value. So subclinical ectasia detected only by TBI. This is another case of very asymmetric ectasia. The right eye is a clinical keratoconus, but the left eye, fellow eye, has normal topography. When we look at the biomechanical assessment and or tomographic biomechanical assessment, actually his bad D value, CBI, and TBI are all completely normal. So we may say that this case may be true unilateral ectasia, not true Fru's case. Actually, many studies actually from different countries reported that TBI is useful in detecting subclinical ectasia. Of course, there is a report from India. So in our study for Japanese population, actually 60% of the VAE with normal topography showed the abnormal values at least one parameter, but the rest of 40% of eyes showed completely normal values in any corneal parameters. So unilateral ectasia is possible. And TBI allows separation of true unilateral ectasia from true Fru's cases. It is important to screening for ectasia risks like familial background, eye rubbing, HP, or allergy. So to know the high susceptibility is very important. Lastly, I'd like to mention about the further investigation of fellow eye of very asymmetric ectasia. As I mentioned, through very asymmetric ectasia with normal topography, it is defined as frumiferous keratoconus. Usually, have the fellow eye has no abnormal sign at slit lamp, no abnormal sign at topography, actually anterior corneal surface. But we don't know whether they have a abnormal value in tomography or beyond the measurement. So if we classify these eyes based on the tomography results, normal or abnormal, we can classify as VAE with normal topography and tomography, or VAE with normal topography. Corvis ST recently introduced the stress strain index. Actually, this is a new parameter. It can estimate the overall stress strain behavior of corneal tissue. Lower values indicate lower material stiffness. So it correlates only with age. Recently, we report the 3-year follow-up of biomechanical changes in very asymmetric ectasia with normal topography. Actually, in this study, we classified these eyes into two types based on the tomography. So VAE with normal topography and tomography, or VAE with normal topography. What we found is significant decrease in SSI, SSI in very asymmetric ectasia with normal topography, but there was no biomechanical changes in VAE with normal topography and tomography. It suggests that possible progressive corneal softening even in a subclinical status such as a very asymmetric ectasia with normal topography such as FFKC.
Things being replaced by Dr. Pooja Kamar, who's going to represent him, and she's going to present on new diagnostic modalities.
So, a very good morning to all. Privileged to be in a session with stalwarts in Keratoconus from whom we learn every day. So, and Dr. Shetty couldn't be here because he's stuck in traffic. So, he's requested me to replace him. I hope I can do justice to what he would have come here and spoken. So, the topic here is newer diagnostic modalities in Keratoconus. So, we do know that we have already existing technologies like Pentacam, Cirrus, and Galilei, which gives us beautiful indices when it comes to diagnosing normal, suspect, and keratoconic eyes. So they are there, but are this enough? We do have a lot of, like this is just going to give an information about the overall corneal topography, curvature, corneal thickness. But the thing is, we have a lot of other structures. We need to look at, when it comes to keratoconus, we need to look at epithelium, stroma, biomechanics, which Dr. Shizuka has already covered beautifully, so I will not go in depth into it, collagen imaging and biomarkers. It's not just about topography or indices, it's much more beyond it. So let's see what each of these parameters or diagnostic indices has hold for us in current day technology or current day practice and in future as well. So coming to epithelium, we do know that epithelium holds a very important role in when it comes to keratoconus, and epithelium will be quite regular in a normal patient, but when a patient has suspect keratoconus or the patient is developing keratoconus or has keratoconus, you see this classic sign of donut pattern in keratoconic eyes. If this is what you see, like you see a C pattern here, you see a blue area here surrounded by a green area. This is called a C sign. This you usually see when the patients have suspect keratoconic eyes or they are developing keratoconus. But in patients with frank keratoconus, you'll see a donut sign. So epithelium actually helps us to pick up what you are looking at, whether you're looking at a normal, suspect, or a keratoconic eye. And it's not just the epithelium thickness or the epithelium mapping. Epithelial aberrations, there are aberrations on the epithelial layer as well. So those epithelial wavefront aberrations also gives you a picture about whether you're looking at a normal epithelium or an abnormal epithelium. For example, if you see this case on the left hand side of your screen, you can see that the epithelium only has an aberration of 0.5 diopters. So this 0.5 diopters is not the entire patient refraction, it's just coming from the epithelium of the patient. And on the right side of your screen, there is no cylinder. And if you see the aberrations of coma, spherical aberration, and trefoil, they will be much higher in this in the epithelium of these patients compared to those of normal eyes. So that just means epithelium is contributing to the cylinder power, and you do see higher degrees of vertical coma and spherical aberration in the patients of this epithelium compared to others. So yes, this does help you in identifying early keratoconus cases. Frank keratoconus cases, yes, you do know that the aberrations are on the higher side, but epithelium can help us in differentiating suspicious from normal corneas, and it can also help us in pick up early subtle changes in these cases. So that does have an important role. Now, corneal nerves are plays a very important role in your cornea, but let's see what impact does it have in keratoconus and cross-linking outcomes. The top layer, what you see is what the healthy nerves look like. You can see nice nerves, and they're branching well. But whenever there is a keratoconus disease, these nerves do get inflamed and they start thinning out, and gradually they start fading away. So this is a typical sign what you might see in keratoconic eyes. And in addition to it, you will also see cells. You can see these white reflective cells on the surface. These cells are nothing but dendritic cells, and dendritic cells are nothing but the inflammatory cells which are present somewhere in periphery of the cornea. They are normally present, but whenever there's an active inflammation, the cells get activated and they come in the center of the cornea, and it's a classic sign of inflammation. So again, you do see dendritic cells immature or mature in cases of keratoconic eyes at times. And if you have a tool of confocal microscopy, you can study this beautifully and see what you're dealing with. Now, what is the role of this nerves? Why are we talking about nerves? Nerves, as I said, this cells are just a sign of inflammation, and this is what a surface would look like. Your inflammatory molecules like MMP9, IL-17, IL-1 beta 6 might be on the higher side. And if you do cross-linking on these patients have much higher chances of developing haze or scar post cross-linking. So why does it come into picture? If there is pre-existing inflammation present, if you do a cross-linking, they have much higher chances of progression. And if you do cross-linking on this inflamed eyes without pre-treating them, they have much higher chance of developing haze or progression, and they will have poor cross-linking outcomes. So that's why it is important to look at that as well. So second comes the stroma. Posterior elevation is known to be there in keratoconus disease, but does the disease starts always posteriorly? The answer is no. The newer evidence does suggest that the disease does start at the stromal elevation layer, and this is how the normal stroma would look like. It's entirely green. That means it's a normal surface. But if you see any yellow or red areas present, means there's stromal elevation present. And if you have a tool which can do a stromal imaging, then you can pick up early cases as well. And it does not just help us in knowing early cases, but it also helps us in diagnosing or differentiating true progression from pseudo progression. For example, this is a case. You can see this is the topography of patient first visit and second visit, classic progression. But let's see what the deeper signs are. This is the epithelium map. This is what I was talking about. In early cases, the epithelium will be of C sign almost, but as it progresses, it does become a frank donut sign. And this is the stromal elevation map. You can see little bit of stromal elevation present, and in a true progression, you will see that the progression also happens on the at the stromal elevation layer. But that's not always the case. Now here you see steepening on the stroma, but you don't see, here you again see the corresponding elevation notice at the stromal level, but this is the second case where you actually see the stroma is not changing at all. So you do identify cases where there is a true progression or not just the topography where the elevation is happening, but also if it's happening at the stromal level or not. I will not dwell into biomechanics because ma'am has already covered into detail, but of course it helps into identifying, differentiating keratoconus from first stage keratoconus cases. It helps us to stage the keratoconus and assess progression, and it helps us in identifying the post-refractive surgery ectasias as well. CBI and TBI, you do have the stress strain index as well. And this is where biomechanics comes into picture. So this is one of the other newer modalities which we have to be careful of, which we can look into. But what's going to be the future is Bruin microscopy. Bruin microscopy is nothing but it actually gives a three-dimensional biomechanics of the eye, and it gives the heat map, which is the true biomechanics of each of the point of the cornea. It's a technology which is at the research level, but slowly and steadily it will come into our practice as well. So in Bruin microscopy, you'll see how the mild keratoconus and advanced keratoconus looks like. As I said, it's an indirect heat map. So normal eye looks like all blue. In mild keratoconus cases, you can see that it's becoming green, and in advanced keratoconus cases, you can see areas of red. That means it's picking up the weakness in a different way. And this is how the maps look into our practice. We do have started working on the Bruin microscopy recently, but the data is too early to share. But this is how the maps will look into in our practice as we move on. Something very interesting which is coming up is collagen imaging. Now, stroma is it comprises of collagen. There are collagen bundles present in the cornea, which are responsible to maintain the strength and the shape of the cornea. And if the collagen fibers are weak, or if they are not held properly, they start slipping away, and that's when you develop the keratoconus disease. So that's why collagen is very important structure of the stroma, and a good collagen distribution and density is very important to maintain the strength of the eye. And lesser it is, or it starts slipping away, that means that's when your keratoconus disease starts to set in. So this is how it looks like. This is collagen bundles, and better the collagen, better the outcomes you will have with your cross-linking disease, cross-linking treatment, and lesser the collagen, the outcomes might be suboptimal as well. But do we have a tool to image that? The answer is yes. We do now have polarization sensitive OCT. What the principle of it is that the polarized light is thrown onto your cornea, and all the structures of the cornea will refract the light back, but the stroma will take the bifringence property of this polarized light, and then that's how you'll get the density and distribution of the collagen in your eye. So we've built a custom built polarization sensitive OCT in collaboration with University of Vienna. This is how it looks like now, but gradually it will look like one of your other OCTs in the practice as well. And this is very beautiful what you see. So now this is something which we all know, the biomechanics and topography. But what does collagen imaging give you? So this is how a normal map would look like. Darker the blue or denser the blue or violet means the collagen distribution and density is good. It's better and it's in a good and optimal quantity. But as I said, the patient starts developing form first keratoconus or an frank keratoconus, there is partial loss of orientation and arrangement of collagen. This is how a form first keratoconic eye would look like. And in a keratoconic eye, you'll see there is complete loss of orientation and arrangement of the collagen. So this is like at this point of time, if you want to know how the collagen is, you can only excise the tissue, be it epithelium or stroma, and you have to do gene expression analysis in your lab. But once you have this tool in your practice, non-invasively, just with a diagnostic technique, you'll be able to know how the collagen orientation and densities for a particular eye, just like a topography, and it will give much in-depth value. And it has applications in stable keratoconus case. Now this is a case example where the topography is stable, but we do not know whether the topography is telling us the truth or not. So you can see that this is the OSI, both the eyes OD and OS. This is the first sitting and this is the second sitting. Without doing any cross-linking, you can see how the collagen bundles are orienting properly. So that means this is a case of stable keratoconus which you are looking at. So whenever you have doubt on topographies, this tool does come into picture and tells you whether it's a true picture what you're seeing on topography or not. And you can also identify the progressor keratoconus cases as well. This is the first sitting, this is the second sitting. You can see the collagen here, it's darker blue colors, here it's becoming light blue. And the Bowman's layer also, we all know Bowman's layer is very important, and Bowman's transplantation does have a role in keratoconus management. You can see that the Bowman's layer is also here, it's green, here it's become more of blue, so that means it's thinning out. So it does give you and here also you can see progression. So beyond topography, it also gives you information about how the Bowman's layer is, how the stroma is, and how will you intervene, at what time will you intervene for keratoconus cases, or for cross-linking or transplant, and what is going to be the prognosis. Looking at topographies nowadays, you cannot actually tell whether you are going to have, after cross-linking, whether the patient will be stable, progress, or it's going to fail, right? So collagen imaging actually can give you a better picture, because if it's a weaker collagen, the cross-linking effect might not be optimal, and if it's a good collagen, it will be optimal. So that is how the polarization sensitive OCT will help us into practice. Now, biomarkers. Biomarkers is nothing but the inflammatory cells which are there on the surface of your eye. Now, if you see this two videos, the left side and the right side, just concentrate on this area. When I put the cursor, it will go away, but I just want to then move it here and this area, okay? So you can see that one cell is being engulfed by the other cell and it's being eaten away. And on the other side, you see that the cell is just there. It's not being eaten away by the other cell. And the morphology of the cells, what we have studied in our school, is very good here and there. You can see the margins of the cell are not very good. So what does this show? Whenever in a normal human body, whenever the dead cells are there, a normal cell will engulf the dead cell and throw it out of the body to create space for the new cells to grow. But
Is it relationship in dry eye and keratoconus?
yes, we do have. So yesterday only I presented the work.
Oh, okay.
So basically this kit is developed for dry eye disease, but we have chosen panel of biomarkers such that it can cover at least 15 diseases which are there, including the retinal diseases. So IL-17, MMP9, IL-1 beta, IL-6, IL-10s, ICAM also. We have ICAM also in our kit. They are the ones which are primarily involved in dry eye disease. So, and we have already developed a AI-based software which will help us differentiate the normal, suspect, like normal or subclinical inflammatory dry eye diseases. And it will tell us also what treatment to give to the patient and not. And why we have chosen this 8 biomarkers to begin with, because we already have treatments in market for this biomarkers. So
with your
why.
program, can it actually classify the dry eye types or cross
Yes, yes. If it would have allowed, I would have shown a slide. But yes, it can differentiate a control, aqueous deficient dry
Aqueous
eye,
deficient,
and evaporative dry eye. For example, ICAM is a molecule what you will see deranged in Sjogren's disease, and IL-17 is the one you'll see in pain without stain. So yes, we do have biomarkers as well, which will differentiate each of these conditions, and it will also tell us if it's a mixed variety or an evaporative dry disease or an aqueous deficient.
Thank you. So corneal transplants, if you see the trend, it has decreased from what was there in last 10 years because of the contact lens and collagen cross-linking. So basically, I'll talk on penetrating keratoplasty, what is the indications and how it is, the surgical steps, how it is different from other indication, complication and visual outcome. Similarly, in lamellar keratoplasty. And at the end, I'll compare between PK and LK. So the indication in penetrating keratoplasty is prior eye drops, not all eye drops, also with large DM detachment. If somebody has a deep stromal scar, especially encroaching the visual axis, and in case you have a large perforation during DALK, you may need to convert to PK. And if the graft has failed because of prior keratoconus, definitely penetrating keratoplasty. The surgical step, I'm not going to detail, but it is same as other penetrating keratoplasty. Preferably, we choose a good quality donor tissue because the recipients are young, and because they are again phakic and clear. Most of the time, it is a clear lens. Meiosis before trepanation is must. Either you take intracameral pilocarpine or before the surgery. Size of trepanation, it varies from like same size, undersize, or slightly oversized. Most of us, because we do from the endothelial side punching for the donor, it is 0.25 or same size. I do personally same size. People take less also, but there are complication like wound gap or astigmatism if you take smaller graft. So basically the size we are discussing here to increase the post-operative myopia. Coming complication again specific to keratoconus, if you see the internal, these are described as step, gap. The internal wound gap, it is in normal PK, it is 50% in corneal transplantation. You see the internal graft host malposition, but in contrast in keratoconus, maybe because of the thinner host, it is quite more, 78.4% you see graft host malposition. Why graft host malposition is important? Because it leads to weaker unstable wound, irregular astigmatism, and optical aberration. Again, complication post PK refractive error, oversized graft lead to increased post-operative myopia. Post PK astigmatism depends on many factors, but especially in keratoconus, it depends on the severity of disease and more unpredictable if it is quite advanced or irregular astigmatism. Most of the keratoconus patient, when I counsel them for contact lens, in fact they want, no, will not use contact lens, will go for transplant. But transplant, again I tell, most of the time you will land up with contact lens. So before at least you try contact lens, then only you plan for transplant. So as I mentioned, astigmatism following PK may be due to donor-related, host-related, or technique. In donor-related, it may be diameter, age, surgery. Check the base of the cone. So the trepanation should cover the entire cone. You see this slit lamp, some people mark it, or you can have an idea before you do trepanation, or you can see the topography. So the recurrence incidence has been reported in 20 years, it is 10%. Recurrence may happen after long, like 17.9 to 21.9 years. But 10% is quite high, but I don't think clinically we see this 10%. But the paper again is not very old. Rejection, keratoconus rejection is not so common like other, but still it has been reported. It can vary from 10% to 35%. But however, most of them are reversible. Maybe they're young people, they come back early. So failure is 2.4%. The risk, like any other PK, large graft, decenter graft, or loose suture leading to vascularization, corneal infection. So this is again one case with PK with a loose suture. This is not a common lysis like PK as well as DALC or for any other indication. Coming to lamellar, which is more common for keratoconus nowadays, the indications are any advanced keratoconus with a healthy endothelium. They're intolerant to contact lens, and like I mentioned, many people do not want contact lens, but I personally send them for a contact lens trial. Despite that, they insist, then it is surgeon choice. A patient with high risk of rejection, if somebody has rejection in other eye and recurrent rejection, maybe you can plan for a lamellar keratoplasty. So it can be divided into anterior, predesmatic and desmatic, but most common is big bubble technique, or followed by, if you're not getting big bubble, then manual dissection. Coming to a few common techniques, the layer by layer dissection is the oldest, and it is preferred in acute eye drops, sealed acute eye drops. In those cases, big bubble is avoided. You do partial trephination, and then you go layer by layer with a spatula or a crescent knife. I prefer old crescent knife. It's a sharp one. You might land up with a perforation. However, the limitation is interface has poor visual quality and recurrence of residual ectasia due to residual stroma. So this is a picture which is due to, you can see the residual stroma. Here there's no residual stroma. So this interface has, but it is fine as long as the vision is good and it is not in the visual axis. Even if it is in the visual axis, at least the rejection chance is not there. Another one is viscodelamination. It is not commonly practiced, but again preferred in cases of scar, like manual dissection. Patient had a full thickness scar due to eye drops. Pneumodelamination is the most common one. Again, out of this, big bubble technique is a popular one. You do the trephination up to 60 to 80%, and mostly vacuum trephine is preferred. You take 30 gauge needle and don't go to the center, because in keratoconus especially there will be a chance of perforation. So you may get a type 1 or type 2 bubble. I'll show a video where the multiple attempts has been done. It's not that one go you can leave it and convert to PK. Even if it's a small perforation at the periphery, you can go ahead and do. So this is a type 1 bubble. Maybe the resident shows there, it is in the center, and there is a type 2 bubble. It starts from the periphery. 1 minute. As I mentioned, preferably vacuum trephine, because it keeps a uniform group. Some people do the air injection just at this stage, and many try to remove the anterior stroma and then inject. The dissector make it. So this is not happening again the second time. So make sure you are not just in the paracentral cornea whenever you are injecting air. This is just a iris, thin iris repositor. There are dark scissors available for the section. So I'll see just clear desmet, but suddenly it perforates and convert it to So the perforation makes sure you're removing whole desmet. Otherwise, sometimes the residual desmet membrane of the host remains. So then the technique is like PK. There are some modification, like for example, this patient had lot of air emphysema. So in those cases, maybe a small air bubble in the antechamber help to know whether we achieved a big bubble or not, because if the bubbles move to periphery. The common complication is perforation. I'll say commonest complication. Most of the time, because we are greedy to go to still deep, then we perforate. The incidence is from 4% to 39%. It can occur in any stage, starting from the beginning or to the end. Most of the time is towards the end. It can be micro or macro. Micro you can manage with fibrin glue, or you leave little bit stroma. Don't go to that place. And double antechamber, the risk is most commonly with corneal scar, then intraoperative perforation, or if you have a type 2 bubble. Or sometimes because the keratoconus was too steep, because of the buckling effect, it creates a second antechamber. And the treatment is inject either AR or C3F8 or SF6. This is a photography where you can see the descent membrane. And this is a triple antechamber. So you can see here 1, 2nd, 3rd. So basically the Dwar's layer is separated. And another common complication in DALK, which is not so common in PK, is Urette-Javalier syndrome, because of the pupillary block. It happens, but so timely diagnosis of pupillary block and doing the paracentesis to reduce the size of gap sometimes help. Otherwise, the graft is clear. Many times the patient complain of glare, and especially it is difficult to manage because the patients are phakic. So to do a pupilloplasty is also a challenge. Another challenging complication, this is one of my patients who developed interface infection just 3-4 days after surgery. So it managed empirically. Otherwise, you remove the suture and scrape the bed, but it is not in the bed. It is mostly in the donor cornea. So it may be due to donor-related infection or surgically. This graft infiltrate is quite old, so it is not early complication. It's maybe PK or DALK. Again, the interface says either you leave residual stroma, the interface says is like this, or the blood vessels come time. Stromal rejection also is reported in, so the lot of blood vessels seen in the interface. To compare between both, the learning curve, as we all know, the DALK is a steeper or longer learning curve. The outcome of during learning phase is bad, but otherwise DALK and PK are comparable. So if you see the visual acuity, even the meta-analysis has shown there is no significant difference. In learning stage, as I mentioned, if the residual stromal bed is 60 micron to 80 micron, then there is a poor outcome. Otherwise, if it is less than that, even if you leave residual stroma, the visual outcome is good. Coming to astigmatism, spherical equivalent, there is no difference. Endothelial cell count rejection in PK is 14% and in DALK it is 5.8%. It is more than normal cell loss. But there is no late endothelial failure. Again, there is no significant difference. However, rejection is expected, endothelial rejection. It is 2.69 times more than the DALK. So to conclude, both enjoy comparable outcome in terms of major aspects such as VCPA, astigmatism and graft survival. Definitely the endothelial cell loss and endothelial rejection are less in DALK. And we can try, especially where the good quality of tissues is scarce. I did not touch Bowman membrane transplantation, which is the latest. I don't have any personal experience of Bowman. It is again technically challenged, but few case reports and literature which is a short-term result of Bowman membrane transplantation is coming up.
Thank you for the nice presentation. So is there any comment or questions from the audience?
Do you believe that the use of intraoperative OCT is really important for performing a successful DA?
Yeah, I think that's the most useful intraoperative OCT.
Yeah.
But it's not available in many places. Yeah, definitely for lamellar surgery, especially DALK and DMEC. DSEC may not be so much, but DALK and DMEC is very good. good instrument to
The
guide.
expense is definitely an issue, but what I feel is that the case that you showed was such a good video. You basically used every quadrant to try and still make the big bubble. So if you have access to intraop OCT, you can start with the manual dissection layer by layer. It'll take time, but you would know where to stop. And as you said, studies have shown that if you leave up to 80 microns, the outcomes are going to be still great. So I think that's one point where intraop OCT is really useful. Thank you so much for your presentation. Thank you. Okay, thanks so much for being here. So I'll be talking about a special situation, cross-linking in patients with Down syndrome, also known as trisomy 21. I do not have any financial disclosures relevant to this topic. It's important to understand that when you're talking about patients with Down syndrome, and I'm sure everyone in the room has seen at least some of these patients every year for other reasons as well, be it cataract, keratoconus, retinal dystrophies, you do come across these patients. The important thing to realize is that even adults with Down syndrome, they come in a separate category. So you need to have access to special techniques, good hospital setting, probably somebody who can look after the social aspect, even great anesthesia team, even when you're doing cataract surgery in these patients. There is a possible association with chromosome 21, but of course, multiple studies have shown that there are multiple loci in terms of keratoconus. So it's difficult to figure out what is causing keratoconus exactly in patients with Down syndrome. Cornea is definitely thinner. Unfortunately, it is missed for many years. And one of the issues is that these patients, they constantly touch their eyes, they rub their eyes. So associated allergies and eye rubbing is a huge problem. So we're going to discuss the difference in this group of patients and normal non-trisomy 21 pediatric patients or juvenile keratoconus patients, role of early diagnosis, cross-linking, preparation, surgical considerations, and post-operative considerations. So routine topography, usually it's pretty much out of question. You can hardly communicate with some of these patients. Of course, there are high-functioning Down syndrome patients, so patients who can follow simple instructions, who have family support. You can tell as soon as the patient walks into your clinic what kind of Down syndrome patient are you talking about. So we do come across patients who are very cooperative. You can do a pentacam or any other topography, but many times it's really not possible. Visual complaints, they would never complain. That's the reason they're not diagnosed for a long time. And if you look at the guidelines published about 2 years ago in JAMA, not JAMA ophthalmology, in JAMA, associations of systemic issues in Down syndrome, there's a consortium. They did not discuss ophthalmology at all. I actually wrote to the editor of JAMA, and they told me that there is a second edition coming soon where they're going to discuss ophthalmic problems. So what I mean to say is there's still a lack of, or I should say there is still ignorance, unfortunately, in terms of getting these patients into an ophthalmology clinic when they are being taken care of on a regular basis by their general physicians. Keratoplasty is very difficult. You can think about doing a DALC, probably safer because of the trauma of eye rubbing. Early cross-linking gives us some hope. You got to educate the pediatricians and special need providers. And of course, you can have to rely on gross ocular changes. It won't be, you wouldn't be surprised if you see a keratoconus patient where you see Rizzuti sign or Munson sign just on gross examination, not even slit lamp. You have to involve the home care provider, parents at a very early stage, treat the ocular allergies, assessment of compliance with medications, with patients as well. Many times parents will tell you, oh yeah, we can do the eye drops. But if you tell them, here's an eye drop, an artificial tear drop, can you instill this in front of me in the clinic? They're unable to do that. So you have to make them realize in a very polite way that it's not as easy as they think it is going to be. And it's, of course, they know their kid better than you do, but you still have to tell them. Eyelid abnormalities have to be corrected. Some patients will have ectropion, some might have some scleral show or lack of thalamus. That needs to be treated, because if you're doing an epi-off cross-linking, you don't want problems later on. And as I said, for high-functioning Down syndrome patients, it is okay to take them to your minor operating room, or if you have an operating table in the room somewhere in your clinic, you can ask the patient to lie down, under the microscope light and see if they can cooperate. You're looking at patient cooperation for an hour, hour and a half, depending on what you're doing. Topical anesthesia, it's difficult. There's this case series of 7 cases where they used a questionnaire-based assessment technique, basically pretty straightforward. And if you look at these questions, sorry, the font is small. If anyone, any trisomy 21 patient gives a good score, that is probably a high-functioning Down syndrome patient. So you can think about topical anesthesia. We started, depending on where you work, it is okay to have a parent in the room to hold the patient's hand during cross-linking. But again, you have to look at your hospital regulations. Another series just with 2 patients. With case 1, they did well. Case 2, they did same-day sequential cross-linking and had problems after that. So this basically paper concluded that lack of patient cooperation is a major challenge. And, bilateral procedure is not the ideal way, because you should do one at a time in these patients and see how it goes. The debate still continues about the efficacy of epi-on and epi-off. In these patients, it'll be useful to leave the epithelium on, but you're also risking the long-term efficacy of cross-linking. Although the jury is still out, many papers have shown that epi-on is as good as epi-off. But in our hospital, pediatric patients and patients who are difficult to sort of diagnose and follow up and image, we try and do epi-off so that you flatten them as much as you can, and the effect can continue for at least 7 to 10 years, and you don't have to repeat the cross-linking. Some folks do partial deepithelization. You can try that, although I can tell you, if you do partial deepithelization or debridement, on day 1, the epithelium is still going to be loose and ready to come off. And it is, as an ophthalmologist, as a surgeon, you will feel helpless if the patient will not let you examine the eye, and that is usually what happens in patients with Down syndrome. So the primary aim is quick and uneventful epithelial healing. As I said, you can try partial debridement. Dr. Farhad Afezi has published, well, actually it's not published, it's on his website, Light for Sight protocol. So basically he said that normal compliance, you can do epi-off under local anesthesia. If the compliance is reduced, you can do epi-on with local anesthesia. But if compliance is poor, you can do epi-on with general anesthesia. We usually come across patients in the 3rd category in our hospital. Most of them, they are not compliant with anything. It's general anesthesia, and for the reasons I mentioned a minute ago, we still do epi-off. So recently we have modified our technique. We do a simple tarsorrhaphy on table, which you can open in the clinic a week later, and you don't have to put a bandage contact lens. And in these patients, it works like magic. So in 1 week, every patient would have healed epithelium, and you can basically, using a slight amount of cooperation from the parents and the family, take out the suture from the tarsorrhaphy, and the epithelium is usually healed. So to conclude, cross-linking in patients with trisomy 21 clearly needs extra precautions and care. Family education is of utmost importance. You have to liaise with the pediatrician and also with the anesthesiologist. People in the room who have done even cataract surgery in Down syndrome and general anesthesia, they would know that it's difficult to put them to sleep, and it's very difficult to wake them up. It takes longer than usual to wake them up, especially if they're paralyzed, the muscles are relaxed. There's a strong role of compliance, as I mentioned, and the procedure of choice depends on the cooperation and the compliance levels. Whenever in doubt, go for general anesthesia, and we still recommend doing epi-off in these patients, as long as you can ensure epithelial healing in these patients. So this is the last slide, just a flow chart of what I just mentioned for checking the compliance and seeing if your patient is a high functional Down syndrome. You can still go ahead and perform cross-linking under topical anesthesia, which it makes your life easier. You can image the patient post-operatively, follow them up. But more than likely, you will come across patients who are not high functional, and then you'll have to follow general anesthesia epi-off protocol. Thank you very much for your attention.
Thank you for the nice presentation. Is there any such cases?
No. So the only specificity we follow is that we do epi-off for every patient for the reasons I mentioned, because of better flattening and long-term effect.
Okay, thank you.
Thank you. Dr. Namta is here.
Session from US. So नहीं वो अडेप्टर से लगता है, अडेप्टर लगाना पड़ता है. Okay, so I would be talking to you about collagen cross-linking outcomes, and what generally cross-linking is used for is for corneal ectasias, for CXL plus procedures or combination procedures, for CXL extra, that is with refractive surgeries, for infective keratitis, and of course as a palliative measure for pseudophakic bullous keratopathy till the time that they are undergoing endothelial keratoplasty procedure. Then for therapeutic keratoplasties, people have used cross-linking for donor corneas, which we have used with good results, and scleral cross-linking also for axial myopia. Now, conventionally, in cases of ectasias, you can follow the conventional protocol, the accelerated protocol, and cross-linking for thin corneas. One can use transepithelial, iontophoresis assisted, contact lens assisted, smile lenticule assisted. Apart from this, the pulse collagen cross-linking, the customized cross-linking, and the CXL plus protocols have also been defined. Now, the very first protocol which was used for cross-linking was the Dresden protocol, and this is the result from the same. The spherical equivalent does decrease, the Kmax decreases, and the endothelial cells, they remain unchanged. Now, this is a systematic review of 5 randomized controlled studies, 3 studies using contact lens as eye control, and 2 studies which used age matched population. And again, in this, it has been shown that the Kmax, it does decrease significantly. The thinnest pachymetry, we know in our experience, does decrease slightly, at least in the initial post-op period. And the best corrected visual acuity does improve, especially when you're following a conventional protocol. Now, these are again studies or outcomes of conventional cross-linking in pediatric eyes. In pediatric eyes also, you can see that there is a significant decrease in the higher order abrasions, and the stabilization of the keratometry, which is as early as first post-operative month. In pediatric eyes, again, it has been shown that there can be recurrences, although there is significant decrease in keratometry in cylinder and improvement in the topographic and the elevation indices as well as abrasions. Progression is known to occur in our own series. We have reported a progression of 18% in children, in where 116 patients were looked at. And again, as has been shown in this study by Dr. Henrique, there is progression to the order of 23%. Outcomes of conventional cross-linking, I think, in pediatric eyes are also known, and very nicely Dr. Jhanji talked about cross-linking in syndromic eyes also. This is a study which looks at the biomechanics and the biomechanics do improve in long-term follow-up as well as in the interim period. As stiffness parameters, they increase and there's decrease in the integrated radius as well as the deformation amplitude ratio. Now, if you look at the outcomes of accelerated cross-linking, which we all do so that the patient has less OT time and the duration for which the UV radiation is given decreases. So these have also shown that the steep K decreases, the Kmax decreases in the various studies, and there is significant flattening which is there. There's also some amount of corneal haze as is expected. And again, in pediatric eyes, there have been results which are acceptable. Progression still occurs in pediatric eyes because of the fact that the collagen turnover happens after every 8 years, and the best corrected visual acuity and spherical equivalent has shown improvement. Now, this is a randomized controlled study of 138 eyes where it was seen after accelerated collagen cross-linking was compared with the conventional cross-linking, and there's a deeper demarcation line when you compare it with the accelerated collagen cross-linking in cases of conventional cross-linking. And both the 9 milliwatt and 18 milliwatt protocols were comparable to the collagen cross-linking in terms of safety and efficacy. Now, this looked at the various energy levels, that is comparison of outcomes of 18 milliwatt versus 9 milliwatt for accelerated collagen cross-linking in 4 studies, that is 329 eyes, and it was shown that 10-minute protocol is better, and mean changes in keratometry, in terms of mean change in keratometry, total corneal, higher order aberrations, and coma. So if we look at the meta-analysis again, which looks at collagen cross-linking versus accelerated cross-linking, the collagen cross-linking across all studies have done better as compared to the accelerated cross-linking, both in terms of keratometry and the demarcation line depth, but accelerated cross-linking was better than the collagen cross-linking in terms of the minimum corneal thickness. However, in other parameters, which includes the visual acuity, the spherical equivalent, astigmatism, Kmax, the biomechanical properties, the subbasal nerve plexus density, and endothelial cell density, there was no significant difference between the two. So this is essentially the summary of the outcomes that I had talked to you about. And that is to say that accelerated collagen cross-linking is as efficacious as conventional cross-linking. Now, in thin corneas, again, several of the protocols have been described, including the hypoosmolar cross-linking, the transepithelial cross-linking with EDTA, benzalkonium, and trometamol, contact lens assisted iontophoresis, and smile lenticule assisted cross-linking. Now, a hypoosmolar cross-linking is what we use at our center for thin corneas, which has shown good results. Transepithelial cross-linking also people have used for thin corneas, but the demarcation line is superficial as compared to the epi-off protocols, and there was progression which was shown in one study in 46% of the cases. These are the outcomes of transepithelial cross-linking in pediatric eyes. Again, this has already been dealt by Dr. Jhanji in details, and this is a meta-analysis of transepithelial versus epi-off cross-linking in 3 randomized controlled study, which shows that the visual acuity improvement is there, which is similar with the epi-off, but the epi-off is more effective in terms of the Kmax decrease. Again, there is a role of oxygen to play in cross-linking, especially when the UV radiation is being given. And this is again a meta-analysis of the same oxygen in cross-linking, which has shown a significant decrease in the mean Kmax and improvement in the visual acuity, and the demarcation line, which is significantly deeper in the oxygen-assisted group. Now, if we compare the demarcation line between the 3 studies, the conventional, the accelerated, and the transepithelial cross-linking, these are the demarcation lines which are shown, and the demarcation line is deeper in conventional and accelerated as compared to the transepithelial cross-linking cases. Contact lens assisted cross-linking in thin corneas have been tried using Dresden protocol. but we've also tried it. But in my experience, I think it doesn't work that well, because the 40% of the efficacy is lost because of the presence of the contact lens, has also been shown by other investigators. And accelerated contact lens protocols have also been tried, but I think in the long term they are not as efficacious as non-contact lens protocols. Then sub 400 protocol for thin corneas have been basically evaluated by Dr. Hafezi, and for this may not be available at all points. And I know that Dr. Narayan Netralaya has also come out with the sub 400 protocol for thin corneas. We haven't tried it, but I'm sure Pooja can give us insights into what it is like. Now, pulse collagen cross-linking is basically for the fact that there is some time for replenishment of the oxygen saturation. And when you talk of the outcomes, apart from the outcomes which improve, it is also important to know what complications can occur in the form of pain, transient light sensitivity syndrome, persistent epithelial defects which have been described, corneal haze, reduction in visual acuity, corneal thinning, and endothelial damage, as well as corneal edema, and of course progression, which is going to be there, which varies between 1 to 8%, and is going to be there with all protocols, given the fact that collagen cross-linking, there is a collagen turnover every 8 years. Now, just a word about cross-linking for infectious keratitis, and as of now, there is not much that can be said about it, because all the studies that are available are retrospective, non-comparative studies, and so you do need multicentric trials to say whether it really works well or not. So to summarize, accelerated protocols show comparable efficacy and safety to collagen cross-linking, decreasing surgical time, though some studies have shown better outcomes with conventional protocols. Oxygen-assisted cross-linking is safe and effective, and transepithelial cross-linking is an alternative in some of the cases. And for thin corneas, again, these can be dealt with the hypoosmolar cross-linking, as well as transepithelial cross-linking, where the outcomes have been shown. Cross-linking is an additional procedure in treating borderline corneas for refractive procedures, which of course I did not cover for the want of the time in this protocol, but I think that's a separate presentation completely and a separate entity completely. So thank you very much for your kind attention.
Thank you, Dr. Namrata. We learned a lot. So is there any questions or comments from the audience?
So, can I ask a question? For pediatric patients, Professor Sharma, do you still use epi-on or you prefer epi-off?
We use epi-off.
Epi-off.
We've, I think, not used in too many cases. We were never into epi-on. We are using epi-off.
Yeah, we were discussing that previously as well.
Yeah.
That this is what.
So, Pooja, can you tell us about your sub 400 protocol?
Farhad Hafezi started talking about it, we went back to the literature to see where it's coming from. So Professor Ebhatswal had devised a nomogram where you can actually see that if based on your corneal thickness, what drops you're using, be it 0.1% or 0.2%, what energy you can use, and you can actually go as low as 250 microns. So we haven't gone till 250 microns, but we do cross-linking now for residual stromal bed thickness of at least 350 with a special consent explaining to the patient that this is a modality which is available, but however it can progress because it's an advanced keratoconus, and if it progresses, we will have to do transplant in future. This just avoids the need of transplant. So we have been doing it for more than 4 years now. We have a calculator where you can just feed in the values and it tells how much minutes you need to do the UV radiation for. The riboflavin is the same time, and we have seen only 2 patients out of around 400 eyes we have done with sub 400 protocol who have progressed. So I think it works quite well for now, and especially for kids, as much transplant you can delay, it's better. Thank you. Thank you, ma'am.
Thank you. Any other questions?
no, we give a second go of collagen cross-linking. Now, what happens is that for all the pediatric eyes, the study that we did accelerated cross-linking. Because pediatric eyes, you say, is less than 16 years, and some of them are older, but they are not that cooperative. But having said this, we found that the repeat treatment requirement was there in these cases. And I feel that if you are doing accelerated cross-linking in first go, then if you have to do a repeat, do a conventional cross-linking. But we have our progression rate in the study in the cohort that we saw was 10%.
Thank you. All right. If no other questions, this brings us to the end of this session. Thank you, all the speakers, and thank you to the audience for attending. Thank you.
Thank you.